Welcome to First Aid Review of Pathology, brought to you by Falcon. This is Dr. Carlo Raj. If you feel as though that further information is needed, please refer to Falcon Online. Pathology. Digressions, objections, delight and mockery, carefree, mistrust or signs of health, everything unconditional belongs in pathology. We'll discuss inflammation in the first section. In the second section, we'll move on to neoplasia. The fundamental principles of pathology are key to understanding diseases in all organ systems. Major topics such as inflammation and neoplasia appear frequently in questions aimed at many different organ systems, and such topics are definitely high yield. For example, the concepts of cell injury and inflammation are key to understanding the inflammatory response that follows myocardial infarction, a very common subject of board questions. Similarly, a familiarity with the early cellular changes that culminate in the development of neoplasias, for example, esophageal or colon cancer, is critical. Finally, make sure you recognize the major tumor-associated genes and are comfortable with key cancer concepts such as tumor staging and metastasis. Apoptosis. Programmed cell death. ATP is required. There are two pathways that you need to be familiar with. The intrinsic pathway occurs during embryogenesis, hormone induction, menstruation, and as a result of injurious stimuli such as radiation, toxins, hypoxia. Changes in the levels of anti- or pre-apoptotic factors lead to increased mitochondrial permeability and release of cytochrome C, and we will see as to how this will then activate caspase. The extrinsic pathway occurs with ligand-receptor interactions. The Fas ligand binds to its receptor known as CD95, or immune cells such as CD8, T killer cells release of perforin and granzyme B. Both pathways lead to activation of cytosolic caspases that mediate cellular breakdown. So yet here's another example of pathways that will converge upon a single enzyme. Characterized by cell shrinkage, nuclear shrinkage, and basophilia known as pycnosis. Membrane blebbing, meaning that the membrane itself will balloon out, kind of like a diverticulum. Pycnotic nuclear fragmentation known as karyorrhexis, nuclear fading known as karyolysis, and formation of apoptotic bodies which are then phagocytosed. No significant inflammation. Once again, I repeat, no significant inflammation. Necrosis. As you go through this, please compare and contrast necrosis versus apoptosis. Enzymatic degradation and protein denaturation of a cell resulting from exogenous injury. Intercellular components extravasate. Inflammatory process occurs unlike apoptosis. The various types of necrosis. Coagulative, think of this as being like a ghost town, may occur as a result of myocardial infarction, heart, liver, kidney. Liquefactive, here the tissue is completely obliterated, could occur in the brain. Infections, bacterial abscess, or pleural effusion in the lungs. Caseous, cheese-like. Often pathologists will refer to it as a cheese-like accumulation as a result of TB or systemic fungi. Aspergillosis. Fatty changes. Individual gets into a car wreck. There is abdominal trauma. Pancreas gets traumatized. May result in fatty change. Saponification. Fibrinoid necrosis may be seen with blood vessels. Gangrenous, there are two types. Dry, if there's lack of blood supply. An ischemic event, known as ischemic coagulative. Or may present as wet gangrene, with infections. Common in limbs and GI tract. Now the two pathways. Apoptosis versus necrosis. The intrinsic pathway occurs during embryogenesis, hormone induction, as we had mentioned earlier, with menstruation or atrophy, such as endometrial lining during menstruation, and as a result of injurious stimuli such as radiation, toxins, and hypoxia. You'll notice on the left, the intrinsic pathway, there's a balance that we were speaking of earlier, the pro versus the anti-apoptotic factors. Bach's oncogene is a pro-apoptotic factor. BCL2 oncogene is an anti-apoptotic factor. When they act upon the mitochondria, and if there's increased permeability of the mitochondria, it will then release cytochrome C, responsible for activation of caspases, which ultimately results in cellular breakdown. Therefore, changes in proportions of anti- and pro-apoptotic factors leads to increased mitochondrial permeability and cytochrome C release. The extrinsic pathway, we had briefly described this earlier, will have a fast ligand, binds to its receptor known as CD95, which then brings about activation of caspase. Killer T cell, CD8 cells, release either perforin or granzyme, which then causes activation of caspase and therefore cellular breakdown. Cell injury. Please compare and contrast reversible versus irreversible. Reversible with oxygen. If there is no oxidative phosphorylation, ETC cannot take place. Decreased ATP synthesis. When there's no ATP, the sodium-potassium ATPase pump has been ceased, therefore resulting in increased accumulation of sodium with water inside the cell, swelling. Nuclear chromatin clumping, decreased glycogen, fatty change, ribosomal detachment, still all part of reversible. Why? Because of decreased protein synthesis. Irreversible changes include pycnosis, karyolysis, karyorrhexis. As soon as you may see signs of calcium influx, there is cellular breakdown via caspase. Plasma membrane damage may indicate irreversible injury. Lysosomal rupture, resulting in release of enzymes, mitochondrial permeability, increased release of cytochrome C, possible activation of caspase. All part of irreversible cell injury. Infarcts, red versus pale. Red, hemorrhagic, infarcts occur in loose tissues with collaterals, including the liver, lungs, intestine, or following reperfusion. Please look for reperfusion injuries. Pale infarcts occur in solid tissues with single blood supply, such as the heart, kidney, and spleen. In the margin, red equals reperfusion. Reperfusion injury is due to damage by free radicals. And if you take a look at the bottom, you'll notice on the left the solid tissues resulting in pale infarcts, and on the right, those organs or tissues with collaterals, including the liver and lung, resulting in red infarcts. Here we will discuss atrophy, a physiologic adaptation. Reduction in the size or number of cells. Causes include, number 1, decreased hormones found in the uterus and vagina, decreased innervation, such as lack of motor neuron supply, decreased blood supply, decreased nutrients, decreased pressure, which may be found with nephrolithiasis, kidney stones, and occlusion of secretory ducts as a result of plugging up that may be seen with cystic fibrosis. Inflammation. The cardinal signs of inflammation include rubor, dolor, calor, tumor, and functional fossa, redness, pain, heat, swelling, loss of function, respectively. Fluid exudation. There's increased vascular permeability, so this allows for fluid to enter the interstitial space. Vasodilation, endothelial injury, all the same concept. Fibrosis. As you'd expect, the type of cell that would appear here, fibroblasts emigrate and proliferate, deposition of extracellular matrix. Resolution. There's a restoration of normal structure. Granulation tissue, highly vascularized, fibrotic. Fistula. During the process of resolution, there might be abnormal communication, anorectal. Scarring may be a result. Collagen deposition resulting in altered structure and function. In acute inflammation, the type of cells that you would expect to see, neutrophils. And if it's immature, you would expect to see band or stab cells, a left shift. In acute inflammation, eosinophil antibody-mediated. Acute inflammation is rapid onset, seconds to minutes, lasts minutes to days. Chronic type of inflammation. Here, you would expect to see mononuclear cells, and if it's deposited in tissues, you're looking at macrophages, characterized by persistent destruction and repair, associated with blood vessel proliferation, fibrosis, granuloma, nodular collection of epithelioid macrophages, and giant cells, that which may be found with TB. And the type of necrosis that associated with TB was caseous. Now we come to the process in which our immune cells, or WBCs, will travel to the antigen. Leukocyte extravasation. Neutrophils exit from blood vessels at sites of tissue injury and inflammation in 4 steps. The 4 steps, in brief review, include number 1, rolling, tight binding to the wall of your blood vessel. Number 3, diapedesis, meaning movement of your WBC through the wall. And then migration, meaning movement towards the antigen in the interstitium. Number 1, rolling. The vasculature or stroma will contain E-selectin, P-selectin, and the leukocyte, your WBC, will contain Sal-Lewis, which will bind to it. Number 2, tight binding. The vasculature or stroma will contain ICAM. The leukocyte will contain LFA1, which is a type of quote-unquote integrin. Step 3 was diapedesis. Leukocyte travels between endothelial cells and exits blood vessel. On the vasculature, you'll have PCAMs 1. On the leukocyte, you'll have PCAM 1. Step 4 is migration, in which a leukocyte travels through interstitium to site of injury or infection guided by chemotactic signals. Vasculature, bacterial products, such as the mnemonic silk, C5a, interleukin 8, leukotriene B4, kallikrein. And on the leukocyte, various factors. Free radical injury. Free radicals damage cells by membrane lipid peroxidation, protein modification, and DNA breakage. Initiated via radiation exposure, metabolism of drugs, phase 1, redox reaction, nitric oxide, transition metals, leukocyte oxidative burst. Free radicals can be eliminated by enzymes such as catalase, superoxide dismutase, or glutathione peroxidase, all part of respiratory burst. And please remember that some of these enzymes, which may be deficient, result in increased free radical damage. Spontaneous decay and oxidants, such as vitamin A, C, and E. Pathologies include, in free radical injury, retinopathy of prematurity, RLP, bronchopulmonary dysplasia, CCl4, carbon tetrachloride leading to liver necrosis, fatty change, acetaminophen, your Tylenol. Number 5, iron overload, hemochromatosis. Number 6, reperfusion after anoxia, example superoxide, especially after thrombolytic therapy. Please pay attention to this. Individual comes in with MI, you provided thrombolytic therapy. Please be very cautious as to reperfusion injury. Granulomatous disease. Examples of conditions in which granulomatous disease would be present. Number 1, TB. Number 2, fungal infections such as histoplasmosis, syphilis, leprosy, cat scratch fever, sarcoidosis, Crohn's disease, borreliosis. Helper T cells secrete gamma interferon, activating macrophages. TNF-alpha from macrophages induce and maintain granuloma formation. Anti-TNF drugs can break down granulomas, leading to disseminated disease. T cells secrete interferon gamma. Macrophages secrete TNF-alpha, contributing to granuloma formation. Transudate versus exudate. Transudate, hypocellular, meaning that this is the fluid that's accumulating in the interstitial space. Example of transudate: if there's right heart failure, there's increased hydrostatic pressure within the vessel, pushing the fluid out into the interstitial space. This fluid is hypocellular. It is protein poor. Specific gravity is 1.012, and it's due to, as I've said, if there's right heart failure, if there is liver cirrhosis, portal hypertension, increased hydrostatic pressure. If the liver is not producing albumin, there's decreased oncotic pressure, resulting of lost fluid into tissue. There is, however, sodium retention. And exudate, seen more with infections. The fluid here is cellular, protein-rich. Specific gravity you would expect to see much higher, greater than 1.020, due to lymphatic obstruction or inflammation. Exudate. Erythrocyte sedimentation rate, ESR. Products of inflammation, example, fibrinogen, part of the coagulation cascade or platelet plug formation, coats the RBCs and cause aggregation. When aggregated, RBCs fall at a faster rate within the test tube, process of centrifuge. Examples of conditions in which there is increased ESR, including infections, inflammation such as temporal arteritis, cancer, pregnancy, systemic lupus erythematosus. Conditions in which there is decreased ESR, sickle cell, altered shape of the cell, will not allow it to sediment. Polycythemia, there's just too many RBCs. CHF, here the increased ESR, or the cause of, is unknown. Congestive heart failure. Iron poisoning. Mechanism: one of the leading causes of fatality from toxicologic agents in children. Cell death due to peroxidation of membrane lipids. The symptoms include acute gastric bleeding. Chronically, there may be metabolic acidosis. Scarring lead to GI obstruction. Amyloidosis. Beta-pleated sheet demonstrable by apple green birefringence of Congo red stain under polarized light. Affected tissue has waxy appearance. Types: primary, protein, AL, derived from immunoglobulin light chain, as may be seen with multiple myeloma. AL equals light chain. Secondary type: protein is AA, serum amyloid associated protein, chronic inflammatory disease. AA equals acute phase reactant. Senile cardiac type: transthyretin, derived from AF. AF equals old fogies. Diabetes mellitus type 2, NIDDM. Protein that is associated with this, amylin, derived from AE. AE equals endocrine. Medullary carcinoma of the thyroid. Protein associated, ACAL. Derived from calcitonin. ACAL equals calcitonin. Alzheimer's disease, beta amyloid. Amyloid precursor protein. Dialysis associated, the protein that is associated with this, beta 2 microglobulin. Derived from major histocompatibility class 1 proteins. On this slide, we'll take a look at two different types of shock. Hypovolemic or cardiogenic, meaning that the heart itself, the pump, has failed, therefore resulting in low output failure. There is increased TPR, total peripheral resistance, because the sympathetic has kicked in, stimulating alpha-1 vasoconstriction. There is low cardiac output, cold, clammy patient. In septic shock, because of infection, possibly gram-negative organisms, there's high output failure. In septic shock, there is vasodilation, decreased TPR, dilated arterioles, high mixed venous pressure, hot patient. This now concludes Part 1 of First Aid Review of Pathology, brought to you by Falcon. If further review is required, please refer to Falcon Online.